Hello, everyone. My name is Ray. I'm a medical student at the University of Medical School, and this is part three, the final part of the three-part webinar series covering liver diseases. Um, so, um, be sure to check out some other videos on this channel if you'd like to see other recordings about my colleagues, and also don't forget to like, comment, and subscribe to the YouTube channel, the Medics.Academy YouTube channel, to get notified of new content, because we're constantly updating as well. And if you're a medical student, don't forget to sign up to the free SDocs program. And if you'd like to do that, the link is in the description below. And don't forget that you can also check out the first two parts of this webinar series if you ever need a revision, and they are on this YouTube channel. So let's get started on the final parts of liver pathology. So last time we touched upon hepatitis B, and today we will finish off hepatitis B and discuss hepatitis C, D, and E. So last time we talked about what hepatitis B is, and we also talked about the presentations, okay? And so how do we diagnose hepatitis B? So we would do a liver function test. Now, if this looks sort of familiar, and then that's because that is exactly the same as hepatitis A. Okay, so liver function tests aren't really specific, and they doing a liver function test alone won't be able to help you differentiate between hepatitis A or hepatitis B, and it doesn't help in chronic hepatitis B that liver function tests are mostly normal, which is why we're more interested in doing a liver serology, hepatitis B serology. So I have an entire slide dedicated to how to interpret hepatitis B serology. This is because this is a very important part in your medical career, as well as your medical exams, okay? I personally have to relearn it every time before I take an exam. So I like you to pay special attention to this part. So if you remember from last part, the hepatitis B virus consists of a surface antigen and a core antigen. And in the serology, we will look at that as well. So first of all, in the serology, we have HBsAg, which is the hepatitis B surface antigen, okay? And if you have the surface antigen of the virus, which means you're acutely infected, okay, or chronically infected, which is straightforward, you will also consider anti-HBs, which is the antibody to the hepatitis B surface antigen, okay? And if you have the antibody, which means either you are currently infected, so that your body is making the antibodies at that moment, or you are immunized of having received the antibody from an external source, such as a vaccine or a previous exposure. Okay. We also have the antibody to the core antigen of the virus. So if you have the antibody to the core antigen, it means that you're immunized. Okay. Okay. But please bear in mind that you will not have the antibody for the core antigen if you're immunized from a vaccine. Okay. And then finally, we have the IgM anti-HBC, which is the IgM antibody to the hepatitis B core antigen, okay, which is only present in an acute infection. Now, once we have all that knowledge, we can interpret the serology itself, which I have included in this table. So in an acute infection, you would have HBsAg, and then you don't have anti-HBs, but you have anti-HBC and IgM. Okay, remember, if you have IgM, then you have an acute infection. In a chronic infection, you will have HBsAg, anti-HBC, just like an acute infection, but you don't have IgM. And that's how you tell apart. If you have anti-HBs, and then you would either be immunized because of vaccine or previous exposure. However, you would only have anti-HBC if you've been immunized because of a previous infection. Okay, you do not have anti-HBC because of a vaccine. Okay, that's how you tell apart. If you have nothing, then that means you've never had the infection before and you're susceptible to the infection. Okay, I highly recommend you screenshot this table or screenshot this slide so you can review in your own time and have a look before your exams. Okay, this is very important and I can't stress enough. Right, so how do we manage hepatitis B? Just like hepatitis A, you must notify Public Health England and local health protection unit because an acute hepatitis infection is a nullifiable disease. And you should refer anyone who has a positive HBsAg to a hepatologist for a management. Unfortunately, we don't have any medications for hepatitis B. So just like hepatitis A, we can only offer supportive management and symptom relief, okay? So rest, hydration, analgesia. And then obviously avoid alcohol, minimize contact, especially minimize sexual contact. Advise pregnant women that the infant should be immunized from birth because there's a risk of transmission. And remember, because you can have chronic infections and all patients with a chronic infection should be under regular review by a specialist. All right, so that's hepatitis B. Now, moving along the alphabet, we have hepatitis C. Hepatitis C is a different virus, which is enveloped in an RNA virus and is extremely infectious, okay? It is a blood-borne virus that has at least 6 strains. We're more interested in genotypes 1 and 3 because those 2 types are the most 2 common types that infect humans in the UK. But you can obviously be infected by more than 1 genotype at the same time. It has an incubation period of 6 to 9 weeks. And then in terms of transmission, it is blood-borne and is transmitted by sexual contact. It is an STI. So risk factors would be sharing needles, IV drug users, pretty much similar to hepatitis B, okay? So remember, it's blood-borne and it's spread through sexual contact. So in terms of presentation, unfortunately, most of the majority are asymptomatic. So it's very difficult to diagnose. Most cases are even not diagnosed. So there could be many people out there wandering around with chronic hepatitis C infection. In terms of an acute infection, if they're really unwell, you could have jaundice, deranged LFTs, or non-specific symptoms like fatigue and malaise. In chronic, it's harder to tell. You will have more specific symptoms and persistently elevated or deranged LFTs. In terms of investigations, we're not using serology as straightforward as hepatitis A and B, but we would use an antibody test and HCV RNA test, okay? So according to the guidelines, if an antibody test is positive, you would send a blood sample for an RNA test. If the RNA test is positive, you repeat the sample for confirmation. Now, if that repeated sample is positive, then the patient has a current active infection. However, if in the first place your RNA test is negative, you repeat the sample after 6 months, okay, after the incubation period. And then if the result is still negative, that means the patient has a previously resolved infection and they should be under follow-up. But be warned, you should warn the patient that although you don't have an infection right now, you have a previously resolved infection, you are not immune to any future infections. Okay? In terms of management, for obviously notify Public Health England and the local HPU, and people with an HCV infection should be under specialist care, okay? And you should seek advice or an urgent referral, okay? Because it's a very contagious blood-borne virus. While you're waiting specialist management, you should conduct all of these blood tests as dictated by the guidelines. Okay, that's a lot of blood results to go, blood tests to do, but all of these are important to look for other comorbid liver disease or other diseases. Okay, and we would offer advice for smoking and alcohol cessation. Obviously, avoid sharing toiletries, toothbrushes, or razors, anything that can spread the virus. Avoid sexual contact, avoid injections. Notify the partner, and you do contact tracing if possible. Okay. Now, unlike hepatitis A and B, we have drugs to treat hepatitis C, and they are called DAAs, direct acting antivirals. So I put a list of DAAs there, okay, for you to have a look. And these are all listed under the NICE guidelines, and they are licensed for usage. Okay, so DAAs are prescribed by a hepatologist or a gastroenterologist with a specialist in hepatology to treat the virus. Okay, and you should regularly follow up the patient and continue to advise lifestyle modification. Okay, so that's all I'd like to talk about for hepatitis C. Now let's move on to hepatitis D. Hepatitis D and E are less commonly talked about, but I think you still need to be aware of these two conditions. Hepatitis D is very unique because it's an incomplete RNA virus, and you would need hepatitis, and the virus would need hepatitis B virus for assembly and replication. So while hepatitis B virus can survive without hepatitis D virus, hepatitis D virus cannot survive without hepatitis B virus, okay? And there are two terms that you need to be familiar with. The hepatitis D virus infection can occur as a co-infection or a superinfection. A co-infection means that both viruses infect you at the same time. A superinfection means that a person has the hepatitis B infection, and then after a while, they get infected with the hepatitis D virus afterwards. As with other types of hepatitis, hepatitis D is uncommon in the UK, but prevalent in Mongolia, Republic of Moldova, and countries in the Western and Middle Africa. The incubation period is about 35 days, and similar to hepatitis B transmission, and the transmission is an STI, sexual contact, and also transmission from mother to infant during birth and delivery. In terms of presentation, it's very difficult, almost clinically indistinguishable from other types of viral hepatitis. Now, a co-infection can cause mild to fulminant hepatitis, fulminant being rapidly progressing, very serious. And a superinfection means that it's extremely high risk of fulminant hepatitis and rapid progression to cirrhosis. Okay, so a superinfection is worse than a co-infection. To diagnose hepatitis D, you would need high levels of IgG, IgM antibody, and a presence of HDV RNA in the blood serum. In terms of management, you would notify Public Health England and the local HPU. Manage as you would for hepatitis B, but there is a management. There is a drug we can give, which is pegylated interferon alpha. Although the evidence is rather limited, this is a recommended treatment. So that's all I'd like to cover for hepatitis D. And finally, we'll move on to hepatitis E. Hepatitis E is an RNA virus, and there are 4 genotypes, okay? Types 1 and 2 are found in humans only. Types 3 and 4 are found in animals and can infect humans. So animals like pigs, boar, or deer, I think. So they're common. Hepatitis E is more common in lower middle income countries with limited access to essential water, sanitation, or hygiene. And in terms of developed countries, it's typically caused by undercooked meats, okay? So undercooked pork, mostly. The incubation period is 2 to 10 weeks, and the transmission is fecal oral route, okay, just like hepatitis A. And the way to remember is that because fecal is spelled with F-A-E, A-E, so hepatitis A and E are spread by the fecal oral route, okay? And then risk factors of hepatitis E include poor sanitation, undercooking meats, blood transfusion, and vertical transmission, okay? So be sure to cook your meat thoroughly, all right? In terms of presentation, just like hepatitis D, hepatitis E is clinically indistinguishable from other types of viral hepatitis and liver diseases. You would have these sort of symptoms, but they are really non-specific symptoms, and you would have these symptoms and signs for other liver diseases as well. Anyway, to diagnose it, you would need specific IgM serology, and you would sometimes do a reverse transcriptase PCR, PCR being polymerase chain reaction. In terms of management, again, notify Public Health England and local health protection units. It is a self-limiting disease that requires no specific treatment. Okay. So that's all I'd like to talk about hepatitis A to E. Now, you might be wondering, going down the alphabet, are there any other letters? So are there other forms of hepatitis? Well, there is a virus called the GB virus C, which is also known as the human Peggy virus and previously known as the hepatitis G virus. So does that mean there is actually hepatitis G? Well, actually no, because later we found out that this GB virus C is an orphan virus. So it means that it infects humans, but it doesn't cause disease. Okay, and it's transmitted by sexual contact, but it's a blood-borne virus and vertical transmission as well. Okay, and then so if you're infected by GB virus C, there is some evidence that a co-infection with HIV can prolong the survival of the HIV patient. And there are also some cases where being infected with GB virus C will not increase severity of hepatitis C during a co-infection. So all in all, it is a rather harmless virus, which was previously mistaken as hepatitis G. Okay, I think this is something that you can be aware of, but it's not as important as the other types of hepatitis. So I wonder if you've noticed that we've skipped a letter, which is F. So is there a hepatitis F? The answer is no. So in 1994, researchers published a paper about injecting a virus into rhesus monkeys causing hepatitis, and they've coined that virus hepatitis F. However, no further research was confirmed whether or not the virus is actually hepatitis F, and thus there is no evidence that hepatitis F actually exists. Okay, so overall, there are only 5 types of hepatitis: A, B, C, D, E. Okay, and one virus formerly known as hepatitis G virus. So this is a table I've made. So this is everything, the key points about hepatitis A to E. Okay, so this table pretty much covers what we've talked about in the last 2 parts of the webinar series. You can have a look at the slide and review in your own time, okay, and have a quick look before your exams. All right, so this is coming to an end of this part of the webinar, and here are the references used in this part. And this is actually the end of the 3-part webinar series of liver pathology. So thank you very much for watching parts 1 to 3. If you have any questions or feedback, feel free to email me with this email. And don't forget to check out some of other recordings done by my colleagues on this channel. And don't forget to subscribe to the Medics Academy YouTube channel. Okay, thank you very much for watching, and goodbye.